So I'm delighted to have Amar here with us today. Amar is from the Endo Guys, and all of you will know him very well from all the courses he runs and all his activity on social media. He's a specialist endodontist. He'll go through his own bio with you now in a moment. And today's topic is irrigation. So the secret to endo success. So thanks very much for joining us today, Amar, and over to you.
Hi, Daniel. Thank you so much for inviting me onto your platform. Fantastic platform. I've got to know so many people through it. And like you've said earlier, it feels like I've known you for a long time. Yeah, I've actually never met you in the flesh. So that should be one thing that we'll take away from today to meet up at some point. So today I'm on irrigation of the root canal system, because I think, as we all know, really through conventional textbooks and knowledge, this all really hinges on the endodontic success irrigation. Really, if we irrigate the tooth well enough and we remove what's in there that's causing all the problems in the first place, we should hopefully get a pretty good outcome. So it's what you remove, not what you put back in, I suppose. So a little bit myself, I graduated in Glasgow in 2009. I did my MFTS in 2013, did my Mendo in 2019, where I studied at Liverpool. I had a fantastic group of people teach me there. Rahat Ali, Fadi Jarad, and Sanj Banderi, as well as many others. Did my DDSC, my doctorate in endodontics as well at the same time, and that was on trauma and ortho. I became a consultant in endodontics at the University of Peninsula, and I currently work in specialist clinics in London, Hemel Hempstead, and Grantham. I'm the director of the Endo Guys UK, which is an educational platform for GDPs, and we run courses all over the UK, in Leeds, Manchester, Liverpool, East Midlands, and soon to be with the Smile Academy. And I'm a visiting specialist at KCL Peninsula and sometimes at Liverpool Dental School. So yeah, it was a great 3 years at Liverpool. I had a really great bunch of guys to work with and study with, a fantastic group of people. So if anyone's ever interested in specialist training, get in touch and let me know. Happy to help, and can get you in touch with the people at Liverpool, which is a great university to learn in. I set this up, then the guys were set up during lockdown as a bit of banter really with me and my friend, because we were getting pretty bored at home, and it's gone from strength to strength, which is really good fun. So let's keep it basic for today. I don't want to go into a lot of depth, but we know that microbial infections are the cause of apical periodontitis. We've known that for years. The treatment really focuses largely on reducing the bacterial load within the root canal system, and this is achieved through the use of instrumentation to enlarge the root canal and to place antimicrobial. So you know, the beauty of all the NiTi systems that we're using at the moment is it just essentially creates a taper, a space for us to get the irrigant to the apical third, and that's really where we want to be getting our irrigant down. And that's what we're dealing with, the bacterial challenges, which is a plethora of bacteria that sit across the depth and length of the dentine into the dentine tubules. These are really difficult to treat. And that's where the mechanical and chemical element come together to get rid of as much of this as possible, and hopefully swing things in the direction to allow the body to start to heal. So endodontics, really in a nutshell, if you've got vital cases, you're trying to remove the bacteria as much as possible before you have toxins periapically, which we know second you have a periapical periodontitis, you're going to reduce your success rate. So we want to prevent that happening in the first place. And if the periapical infection is there already, we want to reduce the bacterial load sufficiently to allow the body to start to heal. So that's endo, really. If you want to bring it down in a nutshell, just reduce the inflammatory processes as much as possible. To do that, we need a number of things. The concept of straight line access, if you're a novice or early endodontist, keep things straightforward to see where the canals are and easy to locate. Locate all the canals, so your MB2s and upper sixes and sevens, your second distals, your lower two canals and lower incisors up to 60% of the time, trying to locate them. Remove all the biofilm, which is all about gaining patency, which improves our outcome by doubling it if you look at Engetal studies, and removing the smear layer, as well as getting the irrigant into the right places within the root canal system. And I'll explain why that is, why that's so important, where the challenges are involved with all of this. The whole thing really hinges on a good coronal seal. We get good coronal seal, shown that we improve the outcomes by 11 folds. Again, that's Engetal studies, and there's lots of other previous studies as well to prove that too. So it's the same. The bacteria is going to come from your mouth through the restoration and into your root canal treatment system in the first place. If you've got a poor, coronal seal, you're going to get bacteria through that again, and that's going to be the cause of your failure of your root canal. So excellent coronal seal is absolutely paramount in the whole process. So it's a balancing act between mechanical preparation and irrigation. And the reason why we say that is if you go for a really big taper, some of the older systems out there, yes, it becomes much easier to get your irrigant into position. But the problem is that you remove a lot of dentine, especially in the pericervical dentine, which is the first couple of millimeters above and beyond and below the CEJ. You really want to preserve as much of that as possible. And that's why file systems have really gone into taking a diet to preserve as much of that dentine as possible, really. If we go for a too skinny a prep, it's great, preserves a lot of tooth substance, but the problem is it might become a little bit more tricky to get your irrigant into position. So you might need a few more materials to get you down there and a little bit more skill to obturate it. So it's a balancing act to get this done. So where are the challenges in root canal therapy or irrigation or root canal system? Well, we know the root canal is a complex network. You've got lots of dentin tubules, accessory canals and lateral canals, furcal canals and molars, anastomosis and isthmi, which connect canals with one another, the apical delta, which has got 98% of the ramifications and deltoids, and then you've got the curved canals, which are very, very difficult sometimes to get around, prepare without causing any problems for yourself, and ledges or separate instruments, as well as how do you get an irrigant around the curve when you've got a quite stiff needle. So that's something that we'll discuss in a moment, how we can counteract that. So these are all things that make irrigation of the root canal system a little bit tricky. Now, mechanical preparation helps us in removing the vital necrotic tissue within the root canal system. It creates sufficient space for your irrigant and your medicament within the root canal system. So it's there to create space. But the downsides to it, unfortunately, is mechanical preparation really can't prepare all aspects of the root canal system. It cannot remove all the vital necrotic tissue, and alone it doesn't really reduce much of the bacterial load. And this is sort of epitomized by this photo or the illustration that we've got here, that you've got this ISO 30K file that is nicely snug at the apical third. However, it's literally not touching anything across its whole length from the middle to the coronal third. And we know from Ove Hofpeter's study that over 53% of the root canal system is completely untouched by your mechanical preparation or your instruments. And this increases the bigger, the more ovoid or flat the canals are. So essentially what you're trying to create within the root canal system is a circle within an ovoid. And so therefore the surfaces of the ovoid on either side need to be cleaned and prepared somehow. And that's where the irrigant really comes in its own self. And we know through CBCT studies that a large chunk of the root canal system is untouched really by your mechanical preparation. That's probably more so the skinnier the file that you use, you might be touching less surfaces. And so it's really important, therefore, in that case, to be able to know how to get your irrigant position, activate your irrigant, make it work, and do as much of the antimicrobial treatments as possible and reduce the bacterial load in the root canal system. And we know that mechanical preparation alone in some studies, there's always question marks about some of these studies, but that it may reduce up to 25% of the bacterial load. And that's mostly the bacteria that's either removed by freshening the dentine on the walls, or what was the planktonic bacteria within the floating bacteria within the root canal system, which was unattached to anything at all. And that gets really washed out even with saline. We also know, if you look at some of Nair's studies, that he's a very, very good researcher in microbiology within endodontics. And he's in one of his studies has shown that great root canal treatment was carried out by himself. The root canal treatment just failed, just didn't work. Apical surgery was carried out and it was looked under a microscope, and it was shown that there was still a lot of residual bacteria, and it's really difficult to prepare the apical third. This is really still a challenge for most of us. It's difficult to treat it for a number of reasons, essentially because of the lateral canals that you've got down there, but you're always a bit worried about sodium hypochlorite accidents as well, so you're always a little bit cautious not to get too close. And you've also got residual microorganisms that are sitting within the isthmi, within the apical third, and some of which can actually grow into extra radicular plaque, which again is really difficult to eradicate because that's outside the canal, so you're not really going to get to that very much. And so therefore you're waiting for the body to deal with the rest that's outside the root canal system, and that might cause persistent infection. So when we're removing the last 3 millimeters of the apical aspect of the root canal system, it's done because of exactly that. It's got so many lateral canals and ramifications that this is the area we want to remove to be able to actually eradicate as much of the bacteria in this area as possible, because this is really difficult to get to treat well and to obturate. Another problem is when we're trying to prepare with night eye instruments, or any instruments for that reason, you're going to create debris. And by having that debris in the root canal system, you may increase instrument mishaps. You may push more of the debris down the canal, where you block it off, can cause ledges when the file wants to go down the area of least resistance. You might push some of this stuff through the apex, which may cause more postoperative pain and negative outcome to healing. So this is as a direct result of the mechanical preparation. So by having some irrigant in the canal, you are allowing the debris to fall into the fluids that can be easily washed out. You can actually cool down the file and also acts as a lubricant. So the irrigant here isn't just antimicrobial in its effect, it actually has other properties too that can help in your mechanical preparation. Now, the role of the irrigant is it has an antimicrobial effect. You have some effect into the dentine penetration. You've got treatment of the uninstrumented surfaces that we've discussed earlier on, prevents packing of the root canal system, and it allows removal of the organic and inorganic debris that's formed when you prepare the root canal system, and also what's there already before we've started. Now, the irrigants of choice that we have at present is sodium hypochlorite, chlorhexidine at 2%, which is what we should be using for endodontics, EDTA 17%. There's other things out there as well. Some are licensed in the UK, some aren't. MTAD, QMix, HEBP, and saline. Now, sodium hypochlorite is still the irrigant of choice. It's got an alkaline pH of 11. It's antimicrobial and bactericidal, which obviously kills the bacteria. It's effective at removing or dissolving the pulpal tissue, collagen, organic tissue, which is essential, especially with the pulpal tissue. You don't want necrotic pulpal tissue to be kept in situ, because that is going to be a substrate for bacteria in the root canal system that can cause failure down the line. Acts as a lubricant, so it's great in the root canal system. So when you're trying to do your treatment, I always flood the canals and the pulp chamber with sodium hypochlorite, and I work through that. It doesn't push through, won't cause any problems, and it lets your file lubricate nicely down the canals. But it's unable to remove the inorganic smear layer, which is formed when you prepare the surfaces of the canal. It's not substantive like chlorhexidine, and it has tissue toxicity. We know that if it goes through, you're going to get a hypochlorite accident. The beauty of it is it works really nice with calcium hydroxide. It seems to remove more remnants of necrotic tissue. And with EDTA, it can remove the organic components within the smear layer, which is pretty good. So you remove the organic and inorganic material together with EDTA. Now, the problem is that you can get a sodium hypochlorite accident with this material, and when it does happen, it's quite frightening. So how do we prevent that? Pre-bending the needle 2 millimeters short of your working length, using a Luroloc side venting needle is really important. Using an index finger and not your thumb or the palm of your hand, which are extremely powerful muscles. Constantly moving the needle, and don't let it wedge in, because the irrigant can only really go in 3 planes, up, down, or sideways. So you don't want to jam it. Essentially, the fluid's just going to get through the apex, and it's pretty scary. I've seen it once before. I don't know if Daniel's ever seen it before, but it's pretty scary. I've seen it once, and it was quite frightening, really. How do we deal with it? Well, the first thing is there isn't really a unified protocol worldwide on this. Different people seem to do different stuff. Different departments in the different university departments, different parts of the UK do it differently. But I've sort of looked at the BDJ. They seem to have a pretty good article on this. So when you have a sodium hypochlorite accident, it will bleed. It will bleed and bleed and bleed within the canal. So some people stipulate that you should irrigate with saline to remove some of the sodium hypochlorite within the canal. Some don't argue against this. I'm probably more for the latter, because you're always worried about pushing it up further up the tissue planes and causing more problems. I would let it just bleed. Use something like Ryoko suction tips, the caterpillar tips, which are really good. Just suction as much of that out as possible. Dress it and close it up. Obviously, tell the patient what's happened. They're obviously going to be quite alarmed by what's happened. Paracetamol, codeine, NSAIDs, and antibiotics are quite useful in this case. Evaluate for paresthesia and anesthesia. Now, obviously, if you've got a large swelling submandibularly or under the eye where the patient's eye starts to shut down, then it's straight to MaxFax for consultation and treatment as they see desirable. Review the patient 24 hours, 2 days, 4 days in a week. And if they've still got residual problems such as paresthesia or anesthesia, it's best to send to MaxFax for a second opinion on these things. And that sort of brings us nicely into the reasons why accurate working length determination is so important in root canal therapy. It's to prevent under over instrumentation of the root canal treatment or the canals. So over instrumentation can cause damage to the apical constriction, overfilling and extrusion of the root canal filling materials, which can be quite uncomfortable and can actually impair and reduce our success rate and prolong healing. You might get increased post-operative pain, and like we said, it might impair the healing rate and success rate of the root canal treatment. If you don't have a good working length determination, then you don't really know at which length you're going to get your sodium hypochlorite or your needle going to go down, especially if you use a 30 gauge needle, which I use. And so therefore you may have an increased likelihood of getting a sodium hypochlorite accident. So working length is absolutely essential. Under instrumentation, as we know, means that we've got areas in the root canal system that's completely untouched, which have not been shaped or cleaned. You're going to get this persistent discomfort, underfilling, poor apical healing. And so again, if you don't have a great working length determination here, you're going to end up with lots of areas in the root canal that are going to probably have residual microbes, especially if the canal itself has a periapical lesion at the end of it. So that's going to become even more problematic. Now, this can be done in a number of ways. Some people discuss the tactile feedback. I mean, I can't feel the apical constriction with a cave file. I'm certainly not at that stage in my career yet to do that. And it's shown to be quite inaccurate. Radiographic determination of working length, that's what we got taught in undergrad, but I'll explain why that's a bit problematic and has its own problems. Paper point technique, where you see bleeding in the tip of the paper point. Again, it's not particularly an accurate way to do this. And electronic apex locators, which are by far the best. There's so many out there in the market. I actually, not because I'm on Daniel's talk at the moment, but I actually do use the Woodpecker. I think it's really, really good. Been using it for a couple of years. Very, very good apex locator at a very reasonable price. But there's lots of apex locators out there. Take home message, use the same one for a long time. You get accustomed to it, and you begin to really believe in its lengths that it gives you. So what's the science? The foramen of the main root canal is the major foramen or major apical foramen. It's not always coincidental with the radiographic or anatomical apex. And we know that the mean apex, so where your foramen is not always coincidental with where you think the tip of the root is. And it could be anywhere between 0.5 and 3 millimeters short of that. The minor apical foramen, or what we call apical constriction, is the narrowest point, and that's where we want to be terminating our root canal treatment. We don't want to be going past that because you're going to technically cause an apical perforation. And that is on average anywhere between 0.5 to 1 millimeter short of the apical foramen. And like we said, that's where we want to finish our root canal treatment. That's your preparation length. Engetal strongly suggested that the root canal fillings, which extend beyond the apical constriction or are short of the 0 to 2 millimeters of the radiographic apex, are associated with a higher chance of endodontic failure. So one's an overfill and one's an underfill. Now, why is that? Why is working length determination with a radiographic apex a bit problematic? Well, we've discussed earlier that we know that the apical foramen, the major and minor foramen, the major foramen, which is apical, the major apical foramen, is actually not coincidental where the apex would be at the tip of the apex of the root. So if we were to assume that that's where it's going to be located, and we prepare to that point thinking that we're actually at the end of the root, we could technically be several millimeters through the apex. So there's inherent flaws which we got taught in undergrad, where you want to get as far down as the apex as possible, take a radiographic working length, and then reduce it by 0.5 to 1 millimeter, and that gets you back into the apical constriction. We know that that's a bit of a problem, and it's inherently flawed because we know that the position of the apical constriction may not be at that point. It might be up to 3 millimeters in a difference. And so therefore, if you reduced it by 1 millimeter, you might be 2 millimeters through. So that's not a way that I like to do this. Daniel, do you do it any differently? Do you still use radiographic apexes, or if you there's
No,
just apex locator?
I'm just exclusively Apex Locator now. I never take a working length radiograph unless I feel something's not right.
Yeah.
And it's but I mean that's a fantastic example, that tooth, because it shows both it on the mesial route. You see what a discrepancy would be if you go with the radiograph, but also on the distal route, the way that the canal splits into two apically. So if you're just like if you think you're a millimeter short on the radiograph, you're actually a lot further short because you've missed the kind of split in the area. And it's so common on kind of routes where it comes down and like you have that apical little delta, which is a real skill. So if you can use that kind of example as kind of a mind map when you're actually doing it, it could be really useful in knowing how to manipulate the files to get into those little areas.
Do you take a master CompA once you've done your prep?
No. So once I've got a steady zero rating, I rely on that.
Okay. So you don't take a master apical with a GP or anything like that?
There's like something unusual, but if I've got but I do always check my zero rating again just right before I obturate. So it's kind of a dynamic process, because the reading you get initially from where before you've kind of done your whole instrumentation, and then once you've the canal opened up, your final reading can slightly change by half a millimeter sometimes, depending on how you've instrumented the canal and how much dentin you've removed.
You've straightened up the canal a little bit, I suppose.
Yeah, exactly.
And again, that's the same concept is agreeable when you're trying to do your working length. I mean, I still take a working length BA just for belts and braces. And again, if your GP point is bang on flush to the radiographic apex, you're probably doing something like this. You're probably through the apex by a millimeter or two. So I would always trim your GP back just in case, so you don't actually get it through the apex. Now, there's a lot of controversy whether or not there's going to cause much of a problem long term. It all depends on how well you've disinfected the root canal system and how clean your GP is. But ideally, you don't want this scenario to be happening in your day-to-day endodontics if you can avoid it. Electronic apex locator, for it to work really well, you need to have 3 consistent readings. And what I mean by that is the apex locator, when it's going up and down the bars, it's going on a steady pace, it's not jumping too much. The numbers on the apex locator don't really mean a great deal. The most important ones is 0, depending on what apex locator you use, I suppose. But either the last bar that goes green or the last bar before it goes red, because once it goes red, you're through. That's when you've got patency. And that's where you want to be measuring from. The reason why we go back 0.5 millimeters, because we've gone from the apical foramen back to the apical constriction. So that's where we want to be, hopefully, doing our treatments. So you need to have 3 consistent readings, and you have to have a really good reference point and make sure you measure that well. I mean, I take this multiple times throughout my treatment so that I'm making sure that I'm consistently at the right reading, especially before I start preparing the root canal system with my master apical files. This inconsistent readings, however, can happen quite frequently. An amalgam restoration is the first and foremost. If you touch anything that's metallic, you're going to get a 0 reading. So one way to prevent that happening is either remove the amalgam restoration or put a bit of PTFE tape around your file, and that will help stop the conductance. Galvanic effect, so if you've got lots of irrigant in the pulp chamber, touching metal, then you've got electricity coming through from your file, you're going to get a good bit of a galvanic effect. Again, just dry the pulp chamber. That usually helps quite a lot. The problem with an apex locator, it only gives you a difference between so it's an algorithm of 2 frequencies between soft and hard tissue. So it doesn't really know the difference between pulp tissue and apex. So if you've got a really premature reading, it's probably just pulpal tissue. So try to irrigate the root canal system well. That will dissolve hopefully as much of the tissue as possible. And that will give you a good consistent reading, hopefully, once you get to the apex. If the file's too small and the apex too large, you're not going to get consistent reading because you're not going to complete the circuit. So that's what leads us to an open apex. Again, you might struggle with an apex locator with that. So you may want a radiographic apex with this one, which might be a little bit more accurate. If you've got a faulty machinery, battery wires that have not been clipped properly, that again is an indication that maybe it's not working very well. So make sure you check it at the beginning of treatment, which I do pretty much every single time, where I put the clip and the lip clip at the same time, just to see if I get 0 or beeping. It means the apex locator is working. If you've got perforation, you're going to get zero reading almost instantly. The zero reading is the most important reading. All the other numbers really don't correlate to very much other than just numbers on a bar. So it's important that you make sure that you've got a good reading. That's a Dual-Pex. I sometimes use that every now and then. It's actually a really nice apex locator by Coltene. Improving the efficacy of sodium hypochlorite, you can actually make it work a little bit better for you with time, temperature, and activation. Concentration 0.5 to 8%. We don't really have it for more than, well, in the UK it's licensed for 5.25%. You do get it in greater concentrations in the rest of Europe and in America, but again, it's not here. I don't think I'd like to use 8%. I think it'd be a bit dangerous if I went through the apex personally. Both low and high percentage concentration of sodium hypochlorite have been shown to be equally effective against in the root canal system. A higher concentration seemed to be maybe better against Efficals and Candida albicans in retreatment cases. 6% was being shown in vitro and test tube studies to be the most effective against the biofilm. But again, we don't really use that concentration at the moment. So if you are using a lower concentration, you just need to use it over a much longer period of time with more frequent intervals and replenishment, and you will get a really good outcome. And it's as good as a high concentration. So, I mean, I use 3%. I think it's the happy medium. I'm always, you know, just like anyone else, I'm worried I don't want to ensue a sodium hypochlorite accident. So if it does happen with a higher concentration, I think it's going to be pretty much a bit more damaging. Lower concentration might be a bit more forgiving, but I think bleach is bleach at the end of the day. So I think it's going to be damaging irrespective. What percentage do you guys you use, Daniel? Any?
I use 5.25%, but I mean, I am very kind of careful with it. But it's kind of more, I think it's more the technique that you use it rather than, I think, as you say, if you extrude it and the needle's engaged, if the needle's engaged in the canal and you inject under high pressure, I think the concentration isn't going to be the critical part in that, whether you have the hypochlorite accident or not. I think it really is, it's the effect of the pressure and the bleach actually getting into the vasculature around the tooth. But for me, it's more kind of the efficiency of the kind of workflow. So I'm trying to use the higher concentration in a kind of careful way. But it kind of depends on what you're doing. So if you're just trying to remove debris at the start of the procedure, you don't need to use bleach at all, or you can use a very, very low concentration. If you're trying to dissolve pulp tissue, then the higher the concentration, the better. If at the end you're just trying to dissolve the biofilm, then again, probably the higher the concentration, the better. So you kind of always have in mind exactly what you're trying to do with the irrigant at the time, rather than having just a kind of set rules for everything.
Yeah, no, I agree. I agree. For retreatments, I use 5.25% for sure. Or if it's like a really stubborn case with a big periapical lesion, I'll use a much higher concentration. The only downside to it is I hate the smell of bleach. It's just it gets you after a while, and the patient gets a little bit freaked out when they smell it themselves. But otherwise, I think it's absolutely fine if you take your time using it.
Yeah.
Temperature, does it really improve things? Well, we know that a lower concentration, if used at a higher temperature, may improve the outcome. Studies have shown anywhere between 50, 100, and 217 times an increase in efficacy at removing pulpal tissue. Again, you have to be a little bit careful with this, because the higher the temperature you go with sodium hypochlorite, you make it a little bit more runny. So essentially, it can become more of a risk for hypochlorite accident. But again, I think it's just with everything, if you do it with caution, you should be absolutely fine. Ways to do it: you can use a System B for 3 to 5 second bursts. You don't want to go too high temperature. You certainly don't want to go over 47 degrees with the System B for a long period of time, because you can actually cause damage to the PDL. I actually was going to upload your video on this, but it just wouldn't come on. Every time I press play, it just said darkened. Another way you could do it is use sonic activation or ultrasonic activation. And because your tooth's already like a basin of heat, essentially, of body temperature, I think you're going to warm up the sodium hypochlorite a little bit more, make it work a little bit better anyway. So I personally don't heat the sodium hypochlorite. I just let the activation do the job for me. But if you want to heat it up, I think there's no issues with that whatsoever. And I know that I think you're talking about the peak tips at the moment. So is that something that you're bringing through at the moment?
We're trying to look at just low cost activation methods. I mean, the cheapest way to activate your hypochlorite is just with your GP points. But sometimes it's like the GP can buckle, or it's not that. You can end up going through a couple of GP points to actually get it down. So ideally you want something a little bit more stiff than GP to unless you're doing big preps. Then if you've got big preps, it's a lot easier because the GP is thick. But I do a lot of smaller preps. So if you're trying to activate it with GP points, sometimes it's just too thin to really kind of have a satisfying shape to obturate. So what we're looking for is to get small little plastic tips that we can attach onto our ultrasonic units and just manually just pump them up and down. So it's the same as kind of GP activation, but with like a plastic carrier that's like autoclavable as well and can be reusable. And then in kind of wider canals, then you can actually use it with ultrasonic energy as well. So you need to have it at very low settings, but it'll just be a very effective kind of cheap way of achieving ultrasonic activation in our cases.
Yeah, I mean, is it running the ultrasonic or is it running at sonic at that point?
Yeah, so you can run it on your ultrasonic machine, but you need to do it at the lower settings. So
Okay.
it'll be like 1, 2.
Yellow.
And again, as you just gauge it on each case.
Yeah.
But because it's kind of it's a polymer material, if you put it high, it's just going to kind of disintegrate. So you need to use it at a lower level for it to work. So we've been playing around with the settings just to try and see what the optimal ones are. But so far it looks like just low settings are the kind of real safe ones to use.
Perfect. And you attach that on like an ET25 or?
So there's a little tip that'll fit perfectly onto.
Okay, nice.
Like so once you have that tip, and the same tip actually you can use for post removals as well. So we're trying to make them multifunctional, and that it's not just, so if you have that tip, you can have it for post removal, for just vibrating grounds, and for this ultrasonic activation as well.
Fantastic, brilliant, fantastic. Well, look forward to play with that when it comes through. That should be good fun. The challenges, however, with irrigants, as we were saying earlier on, it's actually relatively easy to get your irrigant into the coronal middle third of the root canal system. It's actually relatively straightforward. The problem is when you want to get to the apical third, and that's partially due to the depth and dimensions of the canal. Larger areas of the apical canals are uninstrumented, and the complexity of the root canal system at the apex. So that's when you want to think about activating your irrigant just to get it down to position. So aids sodium hypochlorite in improving the tissue dissolution, just gets into the areas that you wanted to get it into. Increase the temperature off a little bit more, which makes it more effective, allows it to go into the anastomosis, lateral accessory canals, improves the irrigation into dentine tubules. It agitates the fluids to improve the organic and inorganic debris removal and improves the cleanliness of the canal. But we're hoping that a cleaner canal is going to give a better outcome, but it doesn't really show that in the studies at the moment. We don't really know what cleanliness actually means. Syringe diameter, 23 gauge, it's about 60, 25 gauge is about 50. They come in different sizes. I use a 30 gauge at the moment, which is pretty good. And I use that first one on the very left. It's the blunt-ended needle, which means that you're only getting a lateral flow of the irrigant. I do also use, which I'll show you in a second, other types of irrigating needles as well for the curved canals. But we know from the studies that we're only getting a clearance of about 1 millimeter to 3 millimeters from the tip of the irrigating needle. So if you are wanting to go down a canal that is curved, you're going to struggle to get your irrigant down there. And with the apical pressure, you're probably not getting it to exactly where you want it to be. So apically, unfortunately, you're probably not getting the irrigant position that you'd like it to be with a stiff needle on its own without any activation. And that's shown with a lot of the fluid dynamic studies as well, which earlier came out in 2007. They've showed this, that we're really not getting the irrigant exactly where we want it to be. And the area that we want it is the apical third. And because that's where we're going to have a lot of bacteria, especially with apical cases or cases with abscesses and sinuses. So with needle irrigation alone, it's just not going to get it down there. You need to push it down a little bit more. I found that these are really, really good. Airflex needles. These are essentially acrylic needles, can go around the curve, side vented, as you can see on the picture on the left. They've been brilliant. I've used them in quite a few cases now. Really, really nice irrigating needles. You have to be a bit careful because they do buckle if you don't put them in the right place, and they can sometimes. I mean, I've had a couple that have clogged up where I've had to change the tip, but overall they've been pretty good. Is that what you're using at the moment?
Yeah. So for them, you need to activate the fluid through them before you put them into the canal. So if you put them into the canal, any debris gets onto the little ports where the fluid comes out, they just get blocked up quickly. Or if calcium hydroxide gets stuck in it, or if any like, because the ports are actually quite small. and then I normally kind of pre-bend them before I put them in as well, just to try and make it more accurate to get the tip in without hitting the canal floor or the kind of pulpal floor. But yeah, if you can, it is frustrating if you do bend it, but it's just they're so nice going around and getting the hypochlorite down to the bottom that it's like those little minor things, or I think they override the advantages to them.
Oh yeah, 100%. Small, you know, small little games with them, which are really good.
I think if you go back to that slide 37, just go back one more. Yeah, that one. So on the Aeroflex on that, you'll get on a kind of a shape like that, you'll get the Aeroflex right down to the last millimeter there. So there'll be absolutely no problem with fluid exchange there. And even sometimes putting the needle in passively into the canal is almost like a dynamic irrigation as well. So you don't have to worry about the vapor lock and all the kind of historically where we used to think about when we weren't able to get our needles down deep, and you used to get like vapor lock in the canals, which the files weren't really able to break down. Now with the kind of Aeroflex, you've got the needle below where the vapor lock is, and you're just washing it back out. So it's a really nice adjunct to the irrigation.
I would definitely give this a go for anyone who hasn't used it. I think it's brilliant. It's really good. And it saves you a lot of hassle as well, to be fair.
And we always try and send sample. We have samples. So if anyone hasn't tried it yet, just let us know and we'll get samples out to you as well.
We've got a few boxes of this stuff, so I've got a lot of it to go through at the moment. There's got so much of this stuff. So the reason why we activate, or why we use ultrasonic activation essentially is using an activating tip at a very high frequency, and you get byproducts of activation. The byproducts are cavitation and acoustic streaming, which are the two things that we were looking for, which we like. Cavitation essentially is micro bubbles that just bubbles. You get small bubbles, they shear on the side of the wall of the dentine, and essentially that should hopefully shear away some of the biofilm with it. Acoustic streaming is just violent movement of fluid, meaning that you don't really get any residual fluid on the sides of the wall, which are doing nothing. You're constantly moving the fluid around, a bit like fluid coming down from a tap in a bathtub. If you don't change, all you're going to get is the fluid in the middle that's moving, but on the sides you get nothing at all happening. And that's what we don't want in endodontics. We want to keep that fluid fresh, changing. And that's why, hopefully, with a bit of either GP pumping or endo activators can also do the trick, but they're not as powerful as ultrasonic activation. Ultrasonic activation, there's lots of systems out there. You've got the AeroSafe tips. I mean, I'm not a big fan of the AeroSafe tip. I've snapped too many of them myself. You need to be pretty careful with them. You've got the Endo Ultra and the 8-teeth ultrasonic units. There's quite a lot of units out there. And I think Woodpecker have released one as well, have they not?
Yeah,
I'm pretty sure I've seen one.
I've always found with the ones that just do that they kind of after a year they tend to kind of give up. So I think now what we're trying to focus on is actually get a better ultrasonic unit that you can use for irrigation, for surgery, for post removal, for instrument removal. I think it's better to get one good kind of unit, and then you can get the actual individual tips for all the different things, rather than buying just a purely ultrasonic irrigation unit. But having said that, it's really nice to have one because it's wireless and it's easy to use, and you just press the button and turn it on. But I think if you're looking for diversity, it might be better to buy an ultrasonic unit that has the diversity to do everything.
You've got the Woodpecker, I think, I've got a really nice machine, the one with the water in it.
Yeah, the D600, I think.
Yeah, it's nice.
Money wise, I think it's really good because the main thing on it actually is the LED light. So it's like the light is really good if you're trying to remove instruments or if you're trying to do surgery. It makes a really just that extra little bit of light along with the microscope makes a huge difference.
Yeah, no, they're really. I haven't tried one yet, but they do look pretty sweet. Quite a nice piece of work. GP pumping is cheap and cheerful. Anyone can really do that in practice. It's basically your master apical cone. Make sure you grab it 2 millimeters short of your prep length. And then say that you need to go up and down the canal 100 pumps a minute. I think that's pretty tedious, to be honest. I think it's just a video to demonstrate how you do that, but it's a tedious way of doing it. However, it's cheap and cheerful, does the trick. A lot of studies show that it's as effective as anything else out there. So if you don't have the money to invest in these things, or you're just a novice starting off with it with endodontics and want to just get good at it, it's just a really good way to start off with it. But just make sure you're not pumping the sodium hypochlorite right to length. so you don't get an accident. So make sure you're a little bit short when you're doing that. Ultrasonic activation, essentially, as this demonstrates, it's violent movement of fluid, and you get all this bubbling that forms. And that essentially, if you've got a small taper, means you're getting irrigant, hopefully pushing against the walls. As you can see with the slow-mo, I mean, I love these things, these slow-mos that come out. That your hypochlorite hopefully should do a little bit more work, and hopefully can remove a little bit more of the debris and the biofilm that's sticking on the side of the wall. Gives you a much cleaner canal. And that's how it would look like inside the root canal system. I've used the 8-teeth one. I think it's really nice. I've used it a few times. I think it's pretty decent. Comes in different tips. Again, be a bit careful with how deep you're going down. Don't want to go as far down as this. I think that'd make me a little bit anxious personally. But I think you see the point. It makes the sodium hypochlorite bubble a little bit more, and that detergent within it really does the trick. So if we look at some of the sort of ink studies, I suppose, with these things, needle irrigation alone, you can see the irrigant going a little bit into the dentine tubules, but again, with passive ultrasonic irrigation, it goes a lot more deeper in. Problem with these studies is the ink itself is a little bit acidic, so I don't know how representative that is of true life. But again, I think it demonstrates that you get the irrigant a bit deeper into the dentine tubules where we want it to be. Chlorhexidine, broad spectrum antimicrobial advantage. It's got lower site toxicity, blacks the foul, bad taste and smell. Substantive for up to 12 weeks. If you look at the Al-Mohammadi systematic reviews, it comes in concentrations of 0.12, 0.2 and 2%. In endodontics, you need the 2%. I think the other ones are just not good enough. Again, we know that 2% is better than the 0.12 and 0.2%. The problem with them is doesn't really have much of a smear layer removal effect. It doesn't really remove any of the organic debris or organic tissue. Its uses are really quite limited endodontics. I mean, I might use it maybe once or twice a year for a really stubborn big lesion, but I don't really use it that often. I mean, I don't know about yourself. Do you use chlorhexidine much?
The same. I can't even remember the last time I've tried to use chlorhexidine. I mean, it's generally like from doing a lot of surgery. It's like when there's failure, it tends to be accessory anatomy rather than an area that you can't access. So it's like so whenever on kind of cases where it's been done really well and there's failure, it's generally that there's a really long isthmus or that there's multiple endodontic paths of exits that just haven't been instrumented the first time. So it's, I think in those cases, it's not just, oh, if I used chlorhexidine, it would have worked. It's just not been actually able to access all the areas where the bugs are.
Have you, what percentage would you say when you've done the apical surgery, you've seen a crack apically? Is it quite often or not as often, or?
No, not that often. I mean, we have a couple of cases, but I mean, I do 4, 5, 6 surgeries a week, and it's not that often. I mean, loads of times you see cemental tears where there's like the cementum is beginning to break off the roots. Loads of time there's like multiple exits, and then occasionally it's like it just looks like there's all kind of plaque on the outside part of the root as well. So they're the more common reasons. It's very rare that you do surgery and it's like everything looks perfect, where the is there and those cases heal and they well. It's nearly always when it's just something else happening.
Do you graft commonly, or do you not?
So it's like just want to get everything really clean, and then just get a really stable blood clot. Occasionally I will use a membrane, occasionally I'll graft, but not that often. It's like, because I like to just see that it's like real bone growing back in over time.
Not automatic healing, basically instant healing.
Exactly.
It's
very
that's the thing is, for me, I'm always a little bit worried about the actual grafting material getting infected if I've not really cleaned the area well. Then you're going to be in a hell of a lot of trouble then very quickly.
And I mean, it always depends on kind of what the long-term plan is. It's like, but in general, even if a tooth has got really kind of poor restorative prognosis, we're doing more and more cases now where we're just literally bone building. So we're going to say, okay, let's do the apical surgery, get all this bone back, and then in 2-3 years' time, the tooth may be removed and another kind of restoration placed. But it's like sometimes that's not. It's kind of almost a wait and see. So we're much slower to make definitive plans now. We're saying, okay, but let's just get the bone back first, and then we'll kind of come back to the decision making later,
Yeah.
which really doesn't fit in with how a lot of people are kind of taught to make treatment plans there and then the patient needs to leave with a treatment plan. I think that's not a really good way to decide, because loads of times we don't know how the early steps of our treatment is going to work out before we kind of do a later stage. So we're doing a lot more kind of staged treatment plans now too.
Yep. Yeah, I agree. No, I agree. I'm the same. I'm trying to save as much as we possibly can, just because if we can get some of that bone forming, you've essentially just created really good bone grafting really for the patient without having to get any artificial bone.
And it's real bone. It's its own host bone rather than kind of artificial bone that's
Mesh. So no, absolutely brilliant. Hypochlorite, yeah, don't mix it with chlorhexidine, as we know. You create this thing called PCA. I mean, like I said, I've got a bottle of chlorhexidine somewhere, but I barely ever use it. I think the only times I do use it is, like I said, big lesions. The occasional time if it's like an open apex and the tooth is quite resorbed, and I don't, I think I'm going to get the sodium hypochlorite through. It's just being careful. But very, very rarely do I really use it, to be honest. Smear layer. So any area that you touch with your mechanical instrumentation, you're going to create a little dust. And that's going to clog up your dentin tubules. And so therefore you can't get your ergonomic position. It consists of dentine, pre-dentine, biofilm, pulp remnants. So it's important you remove that. So you unclog the dentine, you allow the sodium hypochlorite to get in here and clean everything up. Prevents obturation to length sometimes. It can weaken the bond strength if you're going to put post in there. Again, these are quite, how much of an effect that will have, I'm not so sure. But again, it's just trying to remove the smear layer so that you've got a bit of a cleaner canal and you can actually get the hypochlorite into position. EDTA, so that's what's we get in a liquid or a gel. Gel is essentially Glide. I mean, I don't really use Glide at all now. I don't think I've used it for a very long time. I'd certainly be careful with Glide and mechanical instrumentation and eye instruments, because you could technically cause separations when you've got that smear layer dentine / gel coming together as a sludge. It can actually cause some problems for you. So I would say, there's really no need to use Glide. I mean, do you use Glide much? I mean,
I used to use it for years and years, and then I've started using it again a lot, because just the reason I use it now more is because for me, the biggest issue is packing debris laterally. And that's why I really kind of, I'm against, not that I'm against, but I really don't recommend kind of single file systems, because when you've got a big file trying to go down small canals, like all the debris is pushed laterally and into the flutes.
Yeah.
And it's like, I mean, just see from the kind of surgical case that fail, the reason they fail is that because when they're packed in, and the bigger the instrument, the kind of tighter it's packed in, and then it's really difficult to remove it, even if you do use ultrasonic activation as well, when it gets really wedged in. So now my aim, especially when I get down apex and it looks like the anatomy is difficult, I want to get fluid ahead of my file, and then I want to have some EDTA gel on the smaller files to just try and stop the packing of the debris laterally. And I do it now a lot more than what I used to do it. Now I'll do it if it's a vital case, I'll probably be less worried about it. But if it's got a lesion and it's necrotic, then I'll definitely be much more keen to use the gel and try and make sure that there's fluid ahead of my instruments down in the apical third.
So as we were saying, it just removes the smear layer, which is really good for calcified canals. And it's very good with sodium hypochlorite because it works very, very well synergistically to remove the organic and inorganic debris, which is really good. So that's how it would look like if you used EDTA, sodium hypochlorite on its own. And with the EDTA, you just open up the dentin tubules a little bit more. You don't want to do this for too long therefore afterwards, because you can cause some dentine erosion, which still we don't really know the effects of which, what is the long-term problem with that. But some have stipulated that maybe, correlating to vertical root fractures or the start to vertical root fractures. But again, it's very difficult to really pinpoint that to one thing. Irrigation protocol. So after shaping, so this is when you've done all your treatment, you're happy that you've got your working lentil prepared. So I usually do, I use sodium hypochlorite, passively ultrasonic activate it 20 seconds per canal, 3 times over. EDTA for a couple of minutes, and then a final rinse with sodium hypochlorite and passive ultrasonic irrigation. And that's what I've used all the way through my training, and basically what my mentors really taught me to do. But, and do you have any variation to this, or is this roughly what you're you're doing, more or
I
less?
think for me, the first kind of I never really put times on it, so it's kind of like it's kind of more of an intuitive feel.
Yeah, yeah,
Uh, First step is, as I said, trying to stop debris being caught laterally. So second step is then trying to clean any kind of debris out and getting it into solution. I use a lot of the microsuctions as well to try and kind of get the fluid moving through canals. I do heat the hypochlorite as well, though. So sometimes before I go down into the apical part, I'll heat the hypochlorite to try and push it ahead of where the instrumentation is. Because I feel that if I've got fluid in some of those apical deltas and stuff before the instruments go in there, then they're going to be much easier to keep open and clean later as well.
yeah.
But yeah, no, I mean, it's probably time wise, I would probably spend a little bit more time. I probably spend probably half an hour from once it's kind of almost open to finish. It's always tricky. I mean, it's probably not half an hour in all cases, but it's I do tend to have the instrumentation phase done really quickly, and then there is probably half an hour between that and actually obturating.
Yeah, I mean, I'm similar to yourself. I probably my prep once I've got my working length, I'm pretty much done. To be honest with you, it doesn't take me very much longer to finish off, and then I'll spend a considerable amount of time just activating and washing, really, and getting things as clean as possible. And like you said, it's you know, I go through gut feeling to see when I'm comfortable and I'm happy with my irrigant, I'm done. My little thing is when the fluid comes back and it's nice and clear, the same way it goes in.
Yeah.
I'm thinking, yeah, that's a good job, you know, well done. But again, I mean, I don't know if there's any evidence for that. It's just mostly a gut feeling more than anything else.
I think it's one of those, if you've got a very small, narrow canal and you've kind of opened it up well, and there's no lesion on the case, then yeah, you probably don't need to irrigate that well. If there's a big lesion and you can tell already that there's like lateral anatomy on it, then the dynamic irrigation part of it becomes so much more important. So you're just trying to get a feel for each canal on how much irrigation it needs.
Absolutely. No, I absolutely agree. And that's what we were discussing with dentine erosion. Just the dentine becomes, you know, you can remove up to what, 20, you know, it's just 20 microns or something really small of dentine. You start to erode that away over time. It looks moth-eaten. And that's been stipulated to show that potentially it could be a theory for vertical root fractures. But again, very, very difficult to tell, really, because of the mechanical change in the dentine. Mechanical and chemical preparation, again, just really old studies that have shown through old microbiological sampling could reduce it up to 75% with chemomechanical preparation. Again, I think it makes a lot more sense because you've freshened up the dentine, you've got some antimicrobials in there that you're going to reduce things. But by how much, I think it's very difficult to quantify, really, because we've still got a lot of limitations with the antimicrobial samplings that we've got and techniques that we use. The future of irrigation, I think you've got lasers. I think they're the next best thing. They're becoming quite popular these days. I mean, I don't really know a great deal about them, but they're looking quite promising. I think this is the thing that I'm looking forward to the most is gentle wave. I don't know if you know much about it, Daniel, but it's looking pretty promising. I quite like the look of this machine that pretty much does your irrigation for you. And it's showing pretty good success rates at 12-month reviews, which are still too little. I think we need at least minimum of 4 years plus. But I think the technology is looking pretty promising. I've seen quite a few videos on this. It's been done by about 700,000 cases have been done in America already by 1,000 endodontists. It's still not licensed in the UK or in Europe, so you can't buy it yet. But I think it's pretty cool. It's nice technology. It basically uses the acoustic streaming energy that we were discussing earlier on and the fluid dynamics to get irrigants to position. You don't then need to prepare big large tapers. You can keep it really minimalistic. The irrigant is pretty much doing the job for you. Yeah, it's interesting. I mean, I don't know if you know much about it. Have you
Yeah,
reading much about it?
I've seen it in Hawaii when we went to the AE, and I think it was 2009. Yeah, the reason why I'm really interested in the technology, I believe in the kind of more minimal preparations, and the smaller footprint we have on the tooth, the better. And I think any of the technology that it kind of aids us to do that. I think some of the problems with the gentle wave system is just the initial cost of it. It's like, I think it's something like $80,000 or something to buy. But then also on top of that, you have to buy a separate handpiece, which costs about $80 per case.
Yeah.
Build up a
Hood.
four wall kind of core around the tooth for every case as well.
Yeah.
But I mean, the cleaning looks amazing, and so the results that are technically possible with it are really good. And it's yeah, I mean, there's loads. I think endo is massively exciting. I mean, the technological changes that we've had in endo in the last like 10 years have been phenomenal, and I think it's just looks like that the future for endo is really, really bright. As we kind of come to focus to kind of change how a lot of the old teaching was done, and like just kind of getting big straight line access, doing big access cavities. It's like
Big apical preps.
more respectful to the footprint that we leave when we do our treatment.
All the was it 3 or 4 sizes bigger than your last flute and all this sort of stuff that we got taught a long time ago, which I think are
a lot of dentistry has just been really taught in a really mechanical way without actually giving the clinician the opportunity to really, you know, think themselves on each individual case and decide. I think a lot of it then after that was so it's very system based, which again is kind of what we're trying to teach you much more kind of analyze the case that you have in front of you and then decide how you're going to instrument, rather than having set files or set patterns in your mind before you even start. And I think it's a much kind of healthier way to approach cases. Now, it's kind of the opposite to what a lot of dentists want to be told. They want to be given a recipe. You start, you do ABC on every single case and you don't have to think. But actually, as clinicians, you're really going to improve a lot if you do actually take the time out to try and think, what do I need to do to achieve the biological and endo goals in this case, rather than having just a set pattern that you're going to do.
Yeah, no, I agree. I think as an undergrad, I think it makes a lot of sense to have a little bit of a recipe. You've got something to start off with, a building block. And think then as you progress and you read and you study, I think that's when you, especially when you start doing it by hand, I think the more you do off it, the more you then get a philosophy for things. You start to question things more. I mean, I find the more I'm doing stuff now, the more I feel like I know less.
Yeah,
weird, you know, like it's quite a weird scenario. I just feel like, oh, am I doing this right? Am I overthinking this? Is over engineered?
Oh, don't worry. Welcome to my world. It's not, but I think that's a really healthy way to be, though, because I think once you think you know it all, you're in trouble. So it's like every day is a school day. And
well, I mean, I get quite a lot of the clinicians at work come and watch me, and they see like how I do everything methodically. And I don't, you know, nothing stopped, you know, and nothing skipped, no areas, like there's no corner being cut, GPs cleaned and immaculately, you know, placing sodium hypo, and they just don't, they struggle to see, why am I doing every single point, you know, that are you overkilling it? But I think the canal is like a petri dish. It has to be clean, otherwise the whole thing's a waste of everyone's time, you know. Very quickly you can completely recontaminate the whole thing. So I really take my time doing this. Calcium hydroxide, I'm going to touch on it just a little bit, really, just because we're talking about antimicrobials. Fantastic medicament, really, and it eliminates the remaining bacteria in the root canal system, reduces inflammation, neutralizes the LPS, which causes the cytotoxic effect, lipid A. Acts as a barrier, it basically acts as a fake obturate, really, between treatments. Dries the wet canal. I'll explain how that works in a moment. And it works really well with sodium hypochlorite. Just be really careful that you don't extrude it into vital tissues. So maxillary sinus, inferior alveolar nerve. Maxillary sinus not so much, but inferior alveolar nerve and mental nerve, you can burn that you know, the nerve quite badly there. Especially as it's a pH of about 12. So it's just be care must be taken with this stuff. Single versus multiple visits. I mean, again, the Cochrane review that everyone goes on about is the Fagini 2008. It's really no difference between both. One visit may, however, have more post-operative symptoms than two, and might need a bit more analgesia and pain control. Indications for its use is weeping canal, so a canal that you just can't get dry, or if you've got pus discharge, I usually will place sodium hypochlorite, calcium hydroxide, just to let things calm down. Resorptive defects, just to reduce external inflammatory root resorption, again, trauma. Apexification, not so much, or direct and indirect pulp capping, because we've got a lot of really great bioceramic materials now, so you don't really need this anymore. Sealers and obturation, I'm not a big fan of calcium hydroxide based sealers. Personally, I think they dissolve over time, so I'm not a great fan of them. Biggest times I use them really is when you've got sinus, just to let things heal. Re-RCT cases with big periapical lesions or large periapical lesion, full stops, because sometimes I mean, I don't know about you, but I've been stung a couple of times with a few facial swelling, so I've sort of started putting calcium hydroxide in the bigger lesions. When I'm doing re-arsetine, you've got that black pigmented GP, and you've got really bad malodor. I'll just place it in there, belts and braces. Or when I don't have enough time, that's when I'll place it in there and just leave it for a while. The whole thing also hinges on a really good canal seal here. So I'll usually have PTFE tape, IRM, and a bit of GIC over that. If you've got a really poor canal seal, then the whole thing just isn't going to do very well. Any other indications that you can think of that, is there any absolute indications where you're going to use calcium hydroxide?
No, I mean, I tend not to use it that often, and it's ironic. Whenever I do use it, it tends to when I have flare-ups. So it's like, I don't know if I'm just picking the cases that I have the kind of bad feeling about at the start.
Yeah.
So it's probably it probably is just case selection, but it's yeah. I mean, and generally when I do have flare-ups, it's nearly always that I've over-instrumented slightly. It's you just increasing the bacterial load in the lesion, and but having said that, when we do have flare-ups, you tend to have really fast healing. So it's when I get them back for follow-up, it's like that big trauma from the massive immune response tends to like really clean up the granulation tissue, and you tend to see really fast healing in those cases.
I mean, it's but what's your so you're doing most endos single visit now?
Yeah,
probably a large majority of them.
Yeah.
I
mean, assuming that I've got to length, I have enough time to clean it. It's like, and I'm kind of happy with all the step by steps that I've done. The vast majority I try and do in one visit.
And a really good way to get the calcium hydroxide in position is with the Navi tips. You can buy that with Ultracal. It comes in a box with the tips at different lengths and gauges, which are really good. Just be careful when you're placing this in the canal. Make sure you're a millimeter or two short if you're working length. You don't want to push this through. You just want to drizzle it all the way across the length of the canal, and then get a really good canal seal in between appointments. Leaving it 2 to 4 weeks is probably more than sufficient. And similarly to Daniel, I probably do 90% one visit. 2 visits is with cases where I've got big lesion. It's just for me, I think quite a lot of it as well is to do with experience over time. The more you do it, the more you think, well, was that really worth it? Did I really need to do that? So it's there's a lot of not experimentation, but experience plays a big role in all these things as well. So that's how you want the calcium hydroxide to look. Really nice.
No downside to doing it in multiple visits. I mean, it's like especially in cases like that where you have some calcium hydroxide in, it's giving it the maximum chance of getting the kind of lowest bacterial count within the canal before you seal it.
Only downside to it is removing it is a bit of a pain. It's not easy to remove the bloody thing. You have to recheck your length. Sometimes I'm having to re-prep as well just to get it out. So it's a bit annoying. The XP finisher is really good in that respect. It really gets all that stuff out, or as much of it out as possible. But we know through a lot of studies that you'll never genuinely get all of it out. There's always going to be some of it staying in there. So that's how it looks like with a PA. Sometimes I take a PA afterwards to make sure how it's looking. It's not indicated, but
so it just comes down then to choice of sealer if we're doing multiple steps. So if you use like an AH+ sealer and there's loads of calcium hydroxide in the canal, then there's kind of potentially a lot of kind of chemical interactions there. Whereas if you are using calcium hydroxide, and we do know that no matter what you do, even with ultrasonics, it's like still some remnants there. At least with the kind of more bioceramics, they produce calcium hydroxide on setting anyway. So it's a more favorable kind of sealer to use chemically in those kind of lesions as well.
Yeah, definitely agree. And how it works is neutralizes inflammatory processes, cauterizes tissue a little bit because it's a higher pH, and it allows a little bit of bone formation because releasing calcium into the area. So last slide of the day, take home message, irrigation is really the whole thing hinges on really good irrigation. No gold standard irrigant out there currently available because you still need obviously the organic and inorganic elements to be removed. Mechanical and chemical preparation go hand in hand for the best endodontic outcome. Sodium hypochlorite is still the best agent